projects and how did you manage to do it with the Brain Tumor Foundation. So thank you very much, Dr. Stieg, for your big effort, and the floor is yours.
Thank you so much. And I want to thank the entire Speak and also for their Herculean efforts to make this happen, given the complexity on my end. I apologize for not being able to be there. And I would also like to thank Zizi Schnur and the Brain Tumor Foundation, which is responsible for the data that I will be presenting. The Brain Tumor Foundation, of which I'm the president, is an organization founded approximately 10 years ago and is concentrating on the early detection of brain tumors and trying to clarify whether that's beneficial. The major factor that we all are concerned with is, as demonstrated on this slide, is detecting disease too late so that we can't really do anything for our patients. What we presume with screening is that it will be beneficial. And what I want to go through in this talk is to basically talk about cancer screening in general, and then with an overview of the incidence and prevalence of brain tumors, and then specifically apply screening to brain tumors, and finally present our Brain Tumor Foundation's findings with the conclusions that we can derive from that data. So cancer screening has to be the application of a relatively simple and inexpensive test, but the important component is that it has to be able to differentiate and find asymptomatic individuals that are likely or unlikely to have a cancer. The importance of screening is that it has to address, obviously, an important healthcare problem. It has to be available for follow-up and diagnosis and treatment. We need to understand what the natural history of the disease is, and the test has to identify either preclinical or early disease states. Most importantly, as we think about this, it has to be cost effective, and the treatment has to be reasonable for and acceptable to the target population. At the end of the day, there's the cost-benefit ratio, and the benefits have to be not only in the ease of the testing, but also in positively affecting the quality of life and the duration of life. As we all know, there can be adverse effects of screening, and one of those is that it allows us to avoid the easier task of focusing on prevention or early treatment. I think an example of this would be in heart disease. We have made more progress by getting people to change their diets and stop smoking than we have by doing more bypasses and putting stents in place. When we consider screening, we also have to carefully evaluate the cost of the program and whether there's any morbidity related to the test. And if there is more morbidity, how that will impact the patient's life. And many times there may be a false positive, what impact that has from a cost factor and on the patient's life. Many times we will diagnose something that is real, a pseudo cancer, and that may result in increased anxiety and morbidity for the patient. And in the end result, we diagnose a glioblastoma. In the 30 years I've been practicing medicine, we really haven't changed the needle on that disease very much. We've maybe added 2 or 3 months. So is it really of benefit to the society to chase material. This is just an outline of how we do the mathematics to determine whether, can you see my cursor? Okay, so when we look at the disease status, whether the patient has a disease, and is it a true positive, false negative, or true negative, and then the positive predictive value is the equation of true positive divided by true positive plus false positive, and as you can read here. So the criteria for this is a simple mathematical equation. Now, two truths, if two statements are true, then the conclusion also has to be true. So for cancer screening to be true, number one, early stage cancer has a better, it has to be true that early stage cancer has better survival than late stage cancer. And number two, that cancer screening leads to a better stage distribution, and therefore screening leads to a better survival. So for us to rationalize any kind of testing, it has to meet these two criteria. Now, there are certain biases that go into screening, and these are referred to as lead time biases, where the screening detects the disease earlier but does not alter its course. Whereas there's length of time bias, where there's an increased chance the screening program will detect a slower, more indolent form of the disease. Also, as we all know, there's overdetection, or the pseudo disease, that would have remained clinically insignificant for the patient's life, but then we have created anxiety in their life as a result of that test. And I'm sure many of you, when you show your patients the MRI scan with the little white spots, they'll be very anxious about the vascular disease that they might have. In addition to that, when we do screening, we have to be very careful. We're randomly allotting the patients, since that there isn't a self-selection bias in the study. The criteria that we use in the United States for regarding the public policy regarding screening is that the process has to result in the improvement in cancer-specific mortality, and there has to be a true cost-benefit assessment. I think another example of this would be, we can all get CT angiographies for coronary artery disease, but that isn't routinely recommended. There are other screening methods that we use. So we try to find lower cost techniques. There is the cost-benefit ratio as it applies to a specific disease process. So as we think about applying screening to brain tumors, I think we have to take a step back and look at the overall prevalence of brain tumors in our society. And I apologize, this is data that we can obtain from the United States. However, I would think that the numbers are somewhat similar in proportion to your numbers in Europe. So the overall incidence of brain tumors in the United States is 28.6 patients per 100,000 patients. And this is primary brain tumors, so we're talking about 100,000 patients, in which 1/3 of those are malignant and 2/3 are benign or borderline malignant. When we subclassify these tumors on this slide, you can see that the majority of them, fortunately, are benign meningiomas, and then there are tumors of the neuroepithelial origin, of which malignant gliomas not otherwise specified are a smaller proportion, and then there's tumors of the pituitary gland and lymphoma, but you can see that in this patient population, they are not considering metastatic disease. So again, I said earlier that the incidence of brain tumors in our society is 28.6, and the subpopulation of malignant gliomas is 6.6 per 100,000. And this translates into approximately 50,000 glioblastomas, 8,500 diffuse astrocytomas, 6,000 malignant gliomas not otherwise specified, and then anaplastic astrocytomas and oligodendrogliomas, making up a not insignificant number of patients. Now, I will remind you that when we think about screening, probably the most common screening that goes on in America is for breast cancer. And the annual incidence or new diseases, new diagnoses in the United States for breast cancer is approximately 200,000 patients. So we're not in brain tumors, exclude metastatic tumors, we're not at that magnitude, but if you add metastatic tumors, we are getting close to that magnitude, and therefore it might justify being more aggressive with screening programs if we can come up with a relatively expensive mechanism to do that. So what are the risk factors for developing a brain tumor? And they include prior therapeutic radiation, decreased allergies, and there are some immune factors and genetic forms that we see. The genetic component is borne out in certain families, particularly those with gliomas that they may obviously P53, and then there are some uncommon genetic syndromes where we will see patients with an increased number of gliomas, but this accounts for less than 5% of the brain tumor population. We all recognize that patients that were exposed to ionizing radiation from pituitary adenomas, acoustic neuromas, meningiomas, and in particular, earlier in America, they used to treat tinea capitis with radiation. There was certainly an increased incidence of meningiomas, and also seen in individuals in Japan exposed to the atomic bomb. There's some weak data suggesting that dental x-rays may result in increased incidence of brain tumors. Inconclusive evidence is seen in patients with head trauma, patients exposed to disposal compounds, and anticonvulsant use, and on an annual basis, I get a phone call from American TV stations about the incidence of brain tumors as it relates to cell phone usage. There, my knowledge, is only one paper that suggests there may be a linkage. I think if you look at it logically and see the exponential increase in the utilization of cell phones and the relative level incidence of malignant brain tumors, it would be hard to statistically prove that cell phones have an increased effect on our development of brain tumors. So I would next like to take you through some of the data that pertains to brain tumor screening that has occurred both here in the United States and also in Europe as an underpinning for why we pursued screening here with the Brain Tumor Foundation. In 1999, Katzman looked at 1,000 healthy volunteers at the National Institute of Health with a broad age range and a mean age of 36. All the patients had an MRI scan without contrast, and it was read by a single neuroradiologist, and they found at least incidental findings in 180 or 18% of their patients. 15% of them didn't require a referral, 1.8% required a routine referral, and only 1% required urgent referral. And in that population, only 3 patients had a primary CNS tumor, as defined below, for a prevalence of 0.003%. Weber and Knopf looked at 2,500 healthy young males in Germany with a mean age of 20.5 years. And again, all the MRIs were read by a single neuroradiologist. And the findings were similar. They found abnormal findings in 6.6%, and those included arachnoid cysts, Chiari malformations, and 1 patient with a low-grade glioma. The Rotterdam study in 2007 looked at 2,000 patients greater than 45 years old. As we all know, with age, the likelihood of finding disease is going to be higher. The mean age here was 63.3 years, and again, the MRIs were read by this time 2 radiologists, and they find an increasing number of asymptomatic brain infarctions, angiomas, gliomas, 1.8% aneurysms, metastatic disease, and pituitary adenomas. This was published in the New England Journal of Medicine. And if you look at different age epochs, again, you can see that asymptomatic infarcts increase from 4 to 18% as we get older. The incidence of angiomas goes from 0.5 to 1.6%. As we would suspect, aneurysms remain relatively stable. And there's a remarkable increase in the number of white matter lesions, the significance of which remain unexplained. Oz extended the Rotterdam study to enroll an additional 3,800 patients for a total of 5,800 patients, with a mean age again higher of 64.9 years. And amazingly, 60% of the patients had at least 1 follow-up examination. And what they found is 9.5% had incidental finding, 2.5% meningiomas, 2.3% cerebral aneurysm, arachnoid cysts, pituitary. But again, the number of low-grade gliomas is small. When we look at the sex distribution, again, we're not surprised. There's more meningiomas in women, more aneurysms in women, arachnoid cysts are more common in men, a fairly equivalent distribution of pituitary abnormalities, cavernous malformations, and as we would expect, cerebrovascular disease is more common in men. Probably the best data we have is from 2009, published in the British Medical Journal, where Morris did a systematic review and meta-analysis of 16 studies, including the 3 previous studies that I went through, looking at nearly 20,000 subjects from Asia, the United States, and Australia. Excuse me. Their objective was to quantify the prevalence of incidental findings on MRI scans. And I think what's interesting to look at is you can see the 95% confidence intervals, but I think more important aspects to look at is how many scans are needed to render a diagnosis. So for meningiomas, it's 345. And for low-grade gliomas, it's 2,000. And this will be seen, in my mind, to be relevant as it pertains to what we're finding in our data with the Brain Tumor Foundation. And what I would submit is that we should probably not be selling MRI scans only for the diagnosis of brain tumors, but clearly for the diagnosis of all of these other lesions. Now, I'm not advocating that we diagnosis of these lesions in an asymptomatic patient that we should start operating on all of them, but certainly we could get better natural history data on these patient populations than we currently have. And on this second slide is a continuation where we also found, they found inflammatory lesions, arachnoid cysts, colloid cysts, and other abnormalities that we frequently deal with from a surgical perspective. If you look at the prevalence of neoplastic incidental findings compared with non-neoplastic incidental findings, you can see in different age epochs that it varies. The neoplastic incidental findings increase with age. The non-neoplastic are relatively at equipoise until the later stages of life, and we also see an increase, gradual increase in the number of silent infarcts with age. What we do with these white matter hyperintensities, I hope one of you in the audience will have an answer for me. So now I would like to go through what we've been doing with Brain Tumor Foundation, which is a based brain tumor screening study. As I said, the foundation was started over 10 years ago, and through philanthropic efforts, we were able to purchase a mobile MRI unit, and in so doing, we were then able to make arrangements with cities throughout the United States to transport the MRI, put it on a city street, and then randomly have people walk in and get a free T2-weighted MRI scan of the brain. We enroll asymptomatic patients, ages 18 to 80. Patients get an MRI scan and they also complete a patient questionnaire. The MRI scans are read by one of my partners at Columbia University Neuroradiology. And then if there are any positive findings, the patient told us who their primary care physician is, so we send that data to them as a result of the questionnaire. The questionnaire looks at demographics, medical history of headaches, seizures, hearing loss, heart attack, cancer, lifestyle, including smoking and occupation, family history of cancer, cell phone use, and any military service. And what our goal is to try to help understand what benefit we can be to this patient, who is a 49-year-old woman who presented only with right facial paresthesias, underwent an MRI scan, and you can see on the T2-weighted image that she had this restricted image in the right temporal lobe. When an MRI scan was done with contrast, it was a non-enhancing lesion. She went in, she elected to go ahead with surgery, and we were able to achieve a gross total excision. And unfortunately, surprisingly, as compared to the results of the MRI scan, the patient had an anaplastic astrocytoma, which was negative for IDH1, P53, BRAF, EGFR, and MGMT, and 1P19Q. So unfortunately, this is a category that behaves more aggressively. We are hopeful that now with adjuvant therapy, i.e. chemotherapy and radiation, that we may have a positive impact on her life. Obviously, this is anecdotal. This is one case. We need more patients like this so that we can follow them and derive adequate data, versus this 42-year-old woman who only presented with headaches and again had a non-enhancing lesion in her right mesial temporal lobe. She underwent section of this lesion, and it came back as a disembryoplastic neuroepithelial tumor. She effectively is now cured from her disease. So from a surgeon's perspective, there has always been the debate, should we treat, should we watch low-grade gliomas? I would submit just because it looks like a low-grade glioma on the MRI scan, we don't necessarily know that. And obviously, if it is a low-grade glioma, we have the potential for cure. So I would certainly be an advocate for earlier surgery. The specific data, we had the MRI scanner in 4 cities throughout the United States. And surprisingly, in New York City, we only had 57 patients. And I think that was because of the location of the MR scanner. And New Yorkers are naturally skeptical of anything free. But we had an age range, as you can see, extending from 17 to 80, and the mean age was 49 years old. Most of the patients were U.S. citizens. There was a fair split between male and female, and most of the patients were white, but we had a compilation of about 20% of the patients being Asian, Black, or Hispanic. And we classified the findings as no medically significant abnormality, minor findings, abnormal findings, and acute findings. And when we looked at each city, the vast majority of the findings were normal. However, we had minor findings anywhere between 12% and 30% of the patients. And then abnormal findings across the board were between 3 and 5%. Major findings being less than 1%. When we look at them specifically by location, broken down, as I said, level 3 is an abnormal finding. That's what it was classified as. But then the final determination seen here, there was possible aneurysm was benign. We find a pine region cyst, which I think we all agree needs to be followed. Cystic enlargement of the sella would need to be followed. Many of these lesions we would choose to follow or potentially treat. This is also true for the patients in Philadelphia, where we found a large acoustic neuroma, the arachnoid cyst. The aneurysm wasn't true, and were a possible pending diagnosis of encephalitis. In New York City, we had these 2 findings. One unremarkable, and the other one is being followed by an ENT doctor. And our most recent location, Las Vegas, we had a number of findings here that you can see. Overall, we have scanned 514 patients. We found 4 aneurysms, 1 acoustic trauma, 1 pulmonary tumor, 1 metastases to the skull. And thus far, we haven't found any gliomas, but as I said earlier, we have to do a minimum of 2,000 scans to find a glioma in our population. So, in conclusion, what can we say about our results? I would suggest that the Brain Tumor Foundation results, although early, are consistent with what has been reported in the literature. Obviously, we need to increase our data acquisition, and it would be marvelous if we could have a partner on the European continent work with this. And then the relevance of early detection still needs to be clarified. As I stated earlier, how does early detection relate to molecular markers and the natural history of apparently benign MRI scans when the tumor turns out to be an anaplastic astrocytoma? What is the natural history of these diseases, and does early detection affect mortality? Are the treatment results that we're utilizing of benefit? Are we improving the overall survival and improving the quality of life at a cost? The prevalence of glioblastoma is not on the same order as breast cancer, which we know is routinely screened, but when we throw in the total diagnoses of cerebral pathology, certainly at the same level as breast cancer. So, and I would be a strong advocate for screening studies. And the role of early detection and its impact on these lesions also needs to be studied in greater detail to determine what the natural history of these disease processes are. So with that, I'd like to say thank you. And again, I apologize for not being there in person, and I'd be more than happy to entertain a dialogue with you all.